Thank you for coming, and we are privileged to have our guest speaker, Dr. Douglas Adams. He is a 1983 graduate from Wheaton College in biology. Now we didn't have applied health science, so that's okay. In 1983, we didn't have applied health science. He went to graduate school at Tulane University School of Public Health and Tropical Medicine, and got a master's in public health in parasitology and tropical medicine. He then went on to medical school to the University of Illinois at Chicago, and then he did his internship and residency at North Carolina Hospital Bowman Gray School of Medicine. He did a research fellowship at Rush Presbyterian, and then he received numerous honors and awards. He has given numerous presentations and has performed over 350 robotic surgical procedures since 2009. He is currently in Owensboro Medical Health Systems in Owensboro, Kentucky. Please welcome Dr. Adams.
Thank you for coming. How many folks here are headed into the health sciences? All of you. How many physicians want to go into med school? How many physical therapy? So we got a good mix. Good. Thank you, Rick, for inviting me. It's always obviously a lot of fun to come back to your alma mater. And Trevor, thanks for coming so I can come back. I'm going to have to walk back and forth to play some of these videos. But about 3 years ago, I'm a cardiovascular and thoracic surgeon, operate on heart, lungs, and blood vessels. About 3 years ago, began doing robotics, almost because we were challenged to do it by some of the other specialties, and discovered, lo and behold, that this has tremendous applicability in what we do. Right now, robotics is very much, has a lot of momentum behind it. This is the crest of that momentum, and what we're beginning to see is a lot of adoption across the board. So it's a very exciting time in our specialty, because for literally a century, we have not been able to offer patients much other than what folks did in the early 1900s. So that's what we're going to talk about today. Yeah, this is kind of cool. Currently, from a visualization and diagnostic standpoint, we have tremendous technical abilities. This is what's called a cardiac-gated CAT scan. It literally is a three-dimensional picture of what is going on inside the chest. This one was obtained specifically to determine whether or not that tumor you see right there was resectable. It looked like it was astride the pulmonary artery, and the question was, can I get this thing off? And so we got this to give us a good visualization. It, in fact, was resectable, and the patient did very well. But from a diagnostic standpoint, you can do this for any body cavity. So you can literally drop in there and take a look at what's going on. For those cavities, for those places where there's an orifice, the technology that exists for entering those orifices and getting a picture is also equally impressive. This is navigational bronchoscopy, which is a combination of video game animation, real-time video, and a GPS system that is put into the head of the bronchoscope, and you're on a special table. And using CT guidance, you actually track the tip of your bronchoscope down to your destination, your target, for biopsy. So tremendous advances in diagnostic and imaging technology. Now, surgery, we haven't always kept up. Our roots are a little bit archaic. Amputation. This is a lithograph of a hernia operation. You can see the form of anesthesia, tie the guy to the bed. And perhaps the best is trephination, where we cut a hole in the head and took a look at what was going on. I don't think it's an accident this guy is wearing a dunce cap. So anyway, you know, we haven't always been right on top. And in fact, this is my practice, or was until 3 years ago. The majority of lung operations today are done through this incision. 10 inches long, side of the chest, muscle splitting, painful, and every bit as horrible as it looks. This is actually a patient of mine. The majority of bypass surgery or cardiac surgery is done through what's called a sternotomy, division of the breastbone, which is affectionately known by many patients as ripping the breastbone apart, cutting me in half, tearing me in. I mean, this is how people. So where we are today, the majority is still done this way. And instrumentation hasn't been much better. If you look, these are some pictures of some stuff from Roman times, actually. And you get an idea of how basic they were. But if you take a look at a tray that exists in one of my fields, doesn't look all that different. The scissors a little bit fancier, the knife handle's a little bit fancier, but the pickups look just like that. So from an instrumentation standpoint, there have not been a tremendous amount of progress. In fact, cutting edge thoracic surgery up until 4 or 5 years ago was sticking a 15-inch scope into a chest with monocular vision and operating on the back end of about a 10-inch instrument, feeling your way through. That was state of the art. That was until about 1998, when a company known as Intuitive Surgical aimed at the heart, hit the prostate initially in terms of its applicability, but over the course of the last decade has gradually worked the way up the body, from the prostate to the uterus to the kidney, and finally into the chest in the last 4 or 5 years. But the solution that they came up with was a combination of insights from this gentleman, who recognizes this guy, Leonardo da Vinci, ideas dating back to the 1400s, some remote access technology that has a lot in common with the current unmanned Predator and Raptor drone programs, and a couple of visionaries at Intuitive Surgical. And these 3 things came together in the late 1990s and have matured into the most effectively penetrating minimally invasive platform out there, the Da Vinci surgical robot. And that's what this thing is. This is a robot. It obviously doesn't have a mind of its own. It's controlled by the surgeon, and we'll talk about that in a minute. But it's a 4-arm device, 1 camera, 3 working arms, that is connected via cables to a controlling surgeon. It's inserted into the body through these little ports here, and these instruments are detachable, communicate with the robot through the back end and also through the ports. Very cool technology. It's enabling, because you take the monocular vision we talked about and you replace it with 3D HD, and you have the ability to magnify up to 10x. You literally are dropped into the chest through miniaturization of the instrumentation combined with this vision. You're given complete camera control and complete retraction to field control. The dexterity of these instruments is superior to my own wrist and hand. And perhaps the most remarkable thing, which you really take for granted when you use it, is that you have remote real-time response. What you do at the console happens in the body. There's no lag, there's nothing else. Now, will it eventually become wireless? Certainly, but right now the inconsistencies of wireless technology preclude that, although we are beginning to teach remotely. Now, the role of Da Vinci in this, I'm sure many of you all have seen Da Vinci's anatomic drawings, incredibly accurate. This top picture here is actually a cadaveric dissection paired with one of his drawings. This was done in the early 1900s, this was done in 1400. You can see how accurate it was. This picture here from the inside of the right ventricle is every bit as accurate as any of the dissection drawings you see today. And in fact, his examination of the physics of the mitral valve and aortic valve function are tremendous. And obviously this here is a picture of the cardiac structures in the tracheobronchial tree. So many people are familiar with the role of Da Vinci and his dissection of cadavers and so on. Oops. But he had kind of a sidelight business. He created 2 robots during the course of his life, one for the French king, which was a lion, and the other which is pictured here. Through a series of gear mechanisms, he created a robot which, if appropriately powered, could move very similarly to the way you and I would walk. And this is the sketch of one of those gears. What's interesting about this, sorry I have to keep going walk back and forth, is that the robotic instruments mimic this. This is actually the back end of the instrument. Oh, it's in the car. I meant to bring one. The back end of this instrument, which actually attaches to that arm. Those 4 gears create the 4 planes of motion of the instrument. So that's the mechanism, the basic mechanism upon which this instrument is built. Obviously, there's a lot of other things going on, but the basic communication technique is that way. And that gives, as I mentioned, wrist motion of 360 degrees and a tremendous spectrum of miniaturized instruments that allows you to be dropped into the body cavity, whatever it is, and do your work. Let's see if this works. Nope. So that's the instrument side of it. Now the remote access, as I said, some of this technology has been borrowed from the military's remote access. In fact, the initial plans for robotic instrumentation and robotic medicine began with the military in an attempt to minimize casualties of physicians at the front, because they wanted a person to be able, or a robot to be able to assess triage and do some work. But I actually sit at a console somewhere else in the operating room, connected to the robot, which is connected to the patient via cables. So that's the form of remote access we had. As I mentioned, we are beginning to experiment with remote teaching. I'm actually able to sit at my console, and through proprietary wavelengths, I'm able to teach another individual in another city, and that's kind of in the experimental phase. So what does this look like? This is an animation. Let's see if I can turn off the volume here. I want to talk through.
The robot port access lobectomy is a technological advancement for the day.
Okay. This is an animation of how this works. As you can see, the surgeon and the robot are separate. Forearms, patient is asleep, obviously still undergoing general anesthesia. These forearms will be under the control of the surgeon who's sitting at this console. The console is 3D HD, achieved by two different cameras in the single camera that is inserted into the patient. The control is through a combination of foot and hand pedals. You switch instruments by tapping one direction and so on. The actual communication with, or actual access to the patient and communication with the robot occurs through the instruments, as I mentioned, and also through the ports that are inserted. When the robot is docked to the metal of these ports, additional communication occurs. Depending on the procedure you're doing, you introduce a varying number of ports. The most common procedure we do is pictured here. This is taken out a lobe of the lung, and there are 5 ports total. 4 of them communicate with the robot. This 5th white one is for extraction of the specimen. The instruments are the robot is docked, and the instruments are introduced, and you have the ability to place them in and out of the body at will. The reason for the 3 instruments is, for one, you have retraction. The other 2 are actually working instruments. A lesion, tumor, whatever is identified, biopsied if necessary, taken out. And then as far as the lung is concerned, what you then have to do if you're going to remove the specimen is you have to control the vascular and airway structures. So you'd be able to free those up and come in with a stapler, which actually is now robotically mounted, and then separate the 2 lobes from each other, and then you'll extract the specimen through a bag. Generally, the largest incision is about 1.5 inches to 2 inches. So it is, it's that easy. So now, what all is done? What do we do in the cardiac and thoracic arena this way? Well, from a thoracic standpoint, this has probably been the greatest penetrance. Thoracic means chest. About 80% of what I do now is done robotically, involves primarily lung cancer. That's far and away the most significant thing. Other chest tumors are diseases of the esophagus or complications of bad destructive lung disease. In terms of how significant of a problem is lung cancer, and what is really the value of the robot in this arena? Lung cancer is the #1 cancer killer in the country. Highest mortality percentage-wise of patients afflicted. 157,000 deaths in 2011. With the population spike of the 1950s and 60s coming through, it's anticipated that number will probably increase to over 220,000 in the next 2 to 10 years. The problem is the majority of these are detected late. Almost 85% of people are detected when you can't do much of anything. You can treat them with chemotherapy, which bumps their survival by maybe 5%. Radiation, the same problem. There's an increasing emphasis on early detection currently by introducing CAT scans, more effective screening, and so on. Which brings in the question of resection, because the only cure for lung cancer currently is take it out. The survival of an early stage cancer resected appropriately is up to 80%, a significant improvement over 15% of all comers. So, although currently about 60 to 70,000 lobectomies, which is the appropriate therapy for lung cancer, are done a year, it is anticipated that probably in the next 5 to 10 years that number will double. So the ability to offer a procedure that is minimally invasive, that has a whole lot fewer consequences in terms of mortality and morbidity, the ability to return to work and so on, is very, very significant. So in the field of lung cancer, this is probably the greatest impact that the robot is going to have. Just to give you an example, this is actually the very first patient I ever did a chest case on. This is a 45-year-old woman who, much to her dismay, was found to have this spot in her left lower lobe. Incidental finding on a chest x-ray that she obtained for a cough. This was very early in our experience in December 2009. We took her to the operating room with the intention of biopsying this thing. Ended up taking out that lobe appropriately. She was left the hospital on day 3, could have gone home in a couple of days. And by day 6, not post-discharge day 6, but post-op day 6, she was going to church and actively participated in the wedding. That is unheard of with any other form. And it was absolutely remarkable. This was kind of the point at which robotics went from a curiosity to me to serious consideration, because I looked at this woman in the ICU and thought to myself, I've never seen anything like this. Now, what exactly how does a lobectomy look from the inside? We saw the animation. This is the real thing. It's double speed, so y'all don't go to sleep on me. This is separating the the lobe, the right lower lobe, from the tissue in the middle of the chest. On the right is a pair of scissors that actually has monopolar energy, so it's coagulating and cutting at the same time. On the left is a pair of graspers. That vessel, that thing right there in the middle, is a vessel about the size of your thumb. It's draining the blood from that lobe. The blood vessels to each lobe carry about 1.5 liters per minute. This is actually the bronchus, the air tube to the lower lobe. Obviously very important to control this safely. That little gray thing that you see in the middle is a lymph. You can see it right now. That little gray thing right there is a lymph node. Those are very, very important to accurately sample at the time of your surgery, because that determines stage, which then sets the course for the rest for further therapy. So the goal here is, to, as the animation showed, to successfully control these 3 structures: the blood supply in, the blood supply out, and the airway. And then to separate the 2 lobes from each other. So here you see getting control of that airway. It's elective at that point whether or not you're going to take it. We flip the lung over. We're now on the front side. This is the heart down here. And we're actually separating the upper lobe here from the lower lobe. You can see the tumor sitting right here. So the lobes of the lung are varyingly attached to each other. Some folks are completely separate, some folks are completely together, and it's everything in between. So what I'm doing here is we're trying to separate the 2. Once you get that plane in between there, the best thing to do is put a stapler, and you see right here, these are staplers, that we actually staple the lung tissue and it compresses it and seals it. It's important to separate these, because what you're going to find is right underneath there, once you get them separated, is the major blood supply to the lobe. And this occurs in whichever lobe you're doing, upper, lower, middle, whatever. And this is that blood vessel. Again, you're dealing with a structure here that is probably the size of 2 of your fingers together. Got about 1.5 liters of blood going through it a minute, and if you get a hole in it, it empties in a hurry. So, not that I've ever seen that, ever. And this is where probably the most significant part of this procedure comes in, and that is safely controlling this. Because traditionally, this has been what we as surgeons have said, oh man, we have to be able to control this safely. But obviously, if I'm sitting at a console, somebody else is doing this. So some of the companies have stepped forward with some very, very good technology, and you see it pictured here, where there's a guide slipped underneath there, and then you'll see the design of the stapler tip, which actually facilitates a safe passage underneath it. And allows, in our institution, a physician's assistant does that firing, some places first assistant, people of varying technical skills. But this combination is really what creates a safe operation. So you see, it also, the other thing is that little guide lets me communicate very effectively with him or her, so I can tell them you're too high, you're too low, rotate counterclockwise, or so on. But one of the things that's very true about robotics that isn't necessarily true about other operations is it is a team sport. Because the individuals at the table have got to be paying attention to what's going on. You have to communicate effectively. So there you can see that it's stapled. Well, here it's cutting it now, so it staples and cuts. These are now automated. This film is pre-automation, but now you can just pull a trigger and the whole thing fires. So, and now we're going back to that blood vessel you saw that actually drains the blood out of that lobe. Same thing, just close around it and staple. Now when I say staple, these things actually fire in the shape of a B. And depending on what they're closing on, the height of that B is of different heights. Vascular, blood vessels split really tight, 2 millimeters or less. Lung tissue, about 0.6 centimeters, 6 millimeters. And then the final thing is, as I said, that airway. We'll get that thing real quick. You notice the angle here isn't optimal. There's actually an articulation knob on these staples that allows you to adjust it to what's going on. And again, that now has been automated. You can adjust to about any point on 180 degrees. So there's this is the lobectomy, you saw the tumor. So that's the basic procedure. And again, the key to that safety. Sorry about this, you guys. So what difference does it make? Well, in the open era, before we did this, our length of stay in the hospital, 6 days, relatively high complication rates, transfusion, and so on. Robotics, which has been 92% of all the folks we've taken on, length of stay of 3 days if 86% of people are home in 4 days or less, which is huge. I mean, you got 86% of people home before. We were at half of them were home before. And again, the other things we measure have been very, very significantly improved. What about heart surgery? The three components of heart surgery to which robotics is applied: coronary bypass grafting, which is simply taking some form of carrying blood and going beyond blockages; mitral valve repair replacement, which is fixing one of the valves; or closure of congenital defects. In our institution, our volume is such that we do not do the mitral valve. We do those open, but we do a lot of the bypasses. Now this, I don't know if you all have ever seen a cardiac catheterization. This is the diagnostic standard for coronary artery disease. And what this is an injection of dye into the coronary arteries. That catheter that you see peeking out at the top there came up from the groin or from the wrist into the aorta and hooked into the orifice of one of the coronary arteries. Keep it playing here. And what you'll appreciate is there's a caliber change right there. I don't know if you can see. I'll stop it on the next run. But that's a blockage, a so-called blockage. And in this day and age, there are a number of ways. Y'all can appreciate the difference there. See how it comes down, it's nice and consistent, then all of a sudden it kind of almost disappears right here. That can be treated with a stent, or in diabetics, which this patient was, this is better treated by bypass. And that means we take the artery that runs inside the chest and we hook it in beyond the blockage. And that's the best way for supplying blood to the front of the heart in this day and age. Now, how do you do that robotically? What your view here is you're looking into the left chest through the robot. That little line right there is the coronary artery. There's a little thread that's around a hole that's been placed in it. The blood supply has been interrupted by this tape. This is a single shot anastomotic device, CO2 powered. You slide it in there and you'll see this thing drop down and fire it. It fires 12 staples into this artery here and joins it to the coronary artery. And when that's done, and this is the hardest part, the hairiest part of this operation, is extracting this thing from the coronary artery at the same time you're extracting this bypass graft out of the device. Once that's accomplished, you then tie this little thread, sealing up the hole, and then you're left with this. And this is the bypass graft in place. So this is applicable to single and double vessel bypasses on the left side of the heart and the back side of the heart. A tremendous advantage. The length of stay on these folks is 2 days, no division of breastbone. Some of these folks I've done have gone back to, I had one guy who was a farmer who had a farm in Costa Rica. He was in Costa Rica 2 weeks post-op managing his farm. Had another guy who, he came in on a Tuesday. He had hooked up with a woman that he wanted to go see in Alabama, and he gave me till Friday to have him out, and he was in Alabama a week later. So again, tremendous advantage. I guess that kind of defines motivation. This is a CT angio. Going back to that CT angio, or the CT we saw this is a CT taking a look at that graft actually that was done just to document patency. Early on in our experience when we started doing this, we got a lot of these to make sure that what we're doing was something valuable. So that's cardiac surgery. What about other things? Well, there are a lot of other things, a lot of other people that benefit from this that aren't necessarily large numbers. This is what's called a schwannoma, which is a neurogenic tumor. This guy presented to me with some arm pain, 23 years old, 6'4", 275 pounds, big guy. To get at this thing, which is, you're looking at a CAT scan. I don't know if y'all have, CAT scans are cross-sectional x-rays and you look up from the feet. So you're looking from this guy's feet, this is his trachea, this is the very top of his lungs. So this thing is packed in at the very top of his chest. To get at, this is his clavicle, that's the head of his clavicle, actually I'm sorry, this is the head of his clavicle. So to get at this thing in a guy that size would not only be painful for me, it'd be really, really painful for him. It might even involve dividing his clavicle. So pre-robotics, this guy's in for a nightmare. This is the view robotically. There's the tumor right there. This is double speed as well. And this illustrates some of the things that the robot can do that nothing else can. This is being done through 4 little holes. I'm zooming in to get a good view as I separate this thing, which is important because right up here are the nerves to the arm, the blood vessels to the arm, and so on. And in order to separate this effectively, I've got to get a very good view of the neural origin of this thing, where it starts and where it stops, so that I don't damage anything that's still healthy. So you see we're pulling the lung out of the way here. That's a suction irrigator, does both. using it to dissect a little bit. And then you just pull it apart, and you'll see here in a second, we're going to identify where the nerve comes out of this tumor, right here. And again, you only want to take the tumor. You don't want to leave, you don't want to damage any of the nerve. This is, the chain that this is part of controls a lot of things that you don't think about, breathing, etc. And this is the origin, same thing. This is tiny. This instrument here is 1.2 centimeters, so this is half a centimeter at most. Accurate dissection, you couldn't accomplish this. Even this guy was open, you wouldn't have this kind of view. And then lastly, you have to separate this from the blood. This is the subclavian artery. It's about the size of your index finger, very, very tender, easy to damage. And this is the blood supply of this tumor. So you have to clearly identify it and then come in with a couple of clips. And you'll see that here in a second. Unless I already did it. Take that thing off. So again, you know, this is, how often do you see a schwannoma? I don't know, once every 2-3 years. But for this guy was in the hospital 3 days. His biggest post-op complication was hiccups. He had an issue with hiccups post-op, which I never quite figured out why. And this is another group that had tremendous Myasthenia Gravis. Anybody heard of this? Anybody know what Myasthenia Gravis is? This is an autoimmune disorder in which the motor end plate is destroyed by you develop antibodies to the end plate. So you get acetylcholinesterase deficiencies. It's progressively debilitating. People that are perfectly normal start having double vision or something funny with their eyes. And within the course of a year, oftentimes, they begin to have truncal weakness. Their central muscles become weak, and then eventually they become completely debilitated. Historically, medical therapy was the first, acetylcholinesterase inhibitors, which keep the enzymes from breaking down the end plates. And then eventually you might come around to surgical thymus by taking out what's called the thymus, which is an immune system gland that sits right on top of your heart. The exact relationship between the thymectomy and improvement in this, nobody really knew. But the problem was that had to be done through a sternotomy. So people didn't really want to consider having their breastbone cut if there was any other alternative. So by the time they got to being sick enough to do it, to consider surgery, they had a huge surgery which only made it worse. Here's an example of how it's done now. 41-year-old woman presented about 6 months after she had initial eye symptoms. She'd begun to go on to some central weakness. She'd had initial response to meds, but that had stopped. And as you can see here, she's got a little mass right here. That's sitting, her heart, again, CAT scan, looking up from the feet. These are the major blood vessels going to right arm, right head, left arm. So these are, this is, so thymectomy in her. Again, you're looking in from the right chest. This is double speed as well. Obviously, that's the heart. So all this fat is part of the blood vessel, part of the thymus. So you're basically just peeling this right up and off. That's the pericardium. It's a sac around the heart that protects it from me. And you'll just take this thing. You begin to get a sense for the tumor right here, how that tissue doesn't look like the rest of the tissue. So you continue. But again, here you are sitting on top of this. You're very close in terms of the dissection, able to peel it off, and there it's out. So what has it meant to this group of people? Previously, surgery was last-ditch therapy, often done through a sternotomy, had poor outcomes because these people, by the time they agreed to having you split their chest open, they were already pretty sick. Now, surgery is moving up the therapy order because we can do it with a little over a day hospital stay, and the people that I've done recently are back to work within 4 weeks. 80% of these people are better, 60% of them are completely off medicine. So the bottom line is this has been huge for this group of people. Now, how many folks in the United States have myasthenia? 60,000. But for those 60,000 people, that's huge. So from our perspective as surgeons, what we're able to offer is tremendous. We're able to give folks the same therapy that we know is necessary with a whole lot less of a hit. The specialties other than what we do in which robotics has a penetration, general surgery with gallbladders and colon resections, OBGYN, urology, head and neck cancer, all again using the Vinci. Now, the Da Vinci is not the only robot out there. There are about a dozen robotic companies in various specialties, neurosurgeons, orthopods. Actually, there are 2 orthopedic robot companies. But the ability to take the technology that is inherent and intuitive has been expanded to other specialties and is becoming an increasing part of folks' work. So clearly, robotics has allowed us to make a realistic impact on the invasiveness of what we do. There are a lot of studies, and some of them which are being performed at our institution and others, evaluating the efficacy of this. Does it really make a difference? How do people do? So anyway, from our standpoint, it's a huge, huge benefit and progress. So thank you all for listening. Questions?
Okay, those that have questions need to speak in the mic, otherwise the recording doesn't get the sound. So you have questions?
Yes, ma'am. Hey, Dr. Chappell.
I wondered if you would comment on the availability of the technology and how students should be thinking about centers geographically and so on, and who helps support this in certain centers.
Okay. The availability depends on the specialty. As I said earlier, when Intuitive first got into this, they aimed at the heart and hit the prostate and worked their way up. Their first foray was an attempt to do cardiac, but the technology wasn't there. However, the urologist picked it up, and robotic prostatectomy is now standard of care. How do you measure standard of care? Well, penetration, what % of things are done that way, and secondly, is it taught in medical school and residency? And that's where urology is. So that's ubiquitous. You can go anywhere and get a robotic prostatectomy. OBGYN is very similar. They've been in the dynamic growth phase for OBGYN for about 3 years, and about 50% of hysterectomies done in this country were done robotically last year. So again, something that is increasingly present. Urology goes back to prostatectomy. Again, a high penetration. In terms of expanding the things other than prostatectomy, that's a little slower. And so if it's something that you wanted, you'd have to hunt for it. You go online to the Da Vinci site and they can point you in the correct direction. General surgery, the single site cholecystectomy, taking the gallbladder out through one incision using specialized instrumentation, has grown tremendously in the last 6 months. And again, I suspect that anywhere that has a robot, whether it was for prostates or OBGYN, will be doing that kind of general surgery. From our standpoint, if you broke our specialty into 3 categories, bypass, mitral valve, and thoracic. Mitral valve is done only at half a dozen centers well across the country: Cincinnati, Atlanta, Dallas, a couple other places. Bypass surgery, similar, not quite as narrow, but again, you'd have to hunt and peck for that, and that's going to be very much of a site-specific place. Thoracic surgery is very different. The translatability of thoracic surgery is much greater, and there's the same thing that went on with OBGYN and with urology is beginning to occur in thoracic, and I expect within the next 2 to 5 years, you'll see any place that has a robot, you will have the availability of robotic thoracic procedures. Does that answer your question? Okay, yeah. Any other questions?
Other? Wait for the mic, because otherwise they won't hear it.
Hey, Dr. Adams, thanks for coming to
No
spend
problem.
time
Thanks for
with us
coming.
today. Question for you. You mentioned that this is potentially could become wireless if the technology becomes better. Would that potentially prompt physicians not to even be in the surgical room? Would be able to even do this in the comfort of their own home? And if so,
Beach.
Yeah.
Is the thought. Beach.
And also, does doing the surgery with a robot, does that inspire confidence in the patient from what you've seen, and does that actually pull from physician-patient relationship?
Good questions, really good questions. As far as, do I think that patients will ever accept not having their surgeon in their room doing their surgery? No, I don't think so. For highly specialized procedures, do I think at some point you may have a guy in San Francisco who's really good at something doing, somebody in Bogota? Sure, I think that's possible. You're obviously going to have to have tremendously reliable access. What I was referring to with teaching is the ability for me to real-time watch another guy's procedure. And so it's not as important. There's a lag there of about a second. But I'm not, it's not a life-threatening lag. So I think in certain circumstances that may be acceptable. In terms of how patients respond to this, I was actually quite surprised. The population that I serve is primarily rural, mostly high school grads. So not a huge level of education, but within 6 months of us doing this, half the patients that came to us were asking about this. And it was in a positive way because they had seen very, very quickly that, my neighbor had this and it did really well. So it really has, there's a lot of confidence based on what they've seen. And that's when you talk about what makes a difference to why a patient picks a particular surgeon or procedure, that's what it's all about. So, does that answer your question? Yeah. Mm-hmm.
Other questions? About, I don't know that you mentioned this or not, how much of the heart bypasses are done using robotics?
For the first year we did it, we were very aggressive in attempting to apply it, and only 17% were we able to do. Primarily because you cannot get at the right side or the underside of the heart, it's all left-sided. And there are some limitations in terms of the patient's physique. You can take a patient to the operating room with every intention of doing it, but because of something about them, you just can't get it done. So it's in its infancy. It certainly has a role. It's just not as high a penetration as thoracic.
You mentioned about the diabetics that you can't put a stent in. You have to do a bypass. Why is that?
It's not that you can't put a stent. It's that studies have shown that folks with diabetic coronary disease do better long-term with bypass, in terms of overall mortality, reintervention strategies, and so on. So diabetic, you bypass. Other folks you stent. Now, the folks that control the stenting also control the diagnosis, so that doesn't necessarily always happen. So.
Other questions?
Yes.
Is there a large cost difference for the patient about using robots versus just surgery?
$1 million question. Yes, there is. And whenever new technology is introduced into medicine, and I don't know about other fields because it's not what I do for a living, generally speaking, the objections start out with, it's dangerous, takes more time, hard to learn, and once you get through all those, the very last one is, it costs too much. When video-assisted thoracic surgery was introduced in the 90s, that was the stick in the scope and with the long sticks, same objections. That's exactly what's being thrown up against this now by the folks who have become experts in video-assisted. Now, in reality, it is more expensive in the operating room. We took a close look at ours, about $800 to $1,200 more in the operating room based on time and equipment. Each of those instruments has 10 uses, and they cost $200 a piece. So the guys at Intuitive are not stupid business people. They're very smart. However, when you figure in all the costs that are involved in a hospitalization, nursing, x-rays, et cetera, by decreasing length of stay by half, by reducing ICU stay, and by reducing complications, overall, in our hands, this went from a money-losing procedure to a money-gaining procedure from the hospital standpoint by about $3,000 per case. Now, last week I gave our CFO the list of our first 100 cases and just said, will you tell me if you made money here? Not because I care about it, but in terms of the broad-based acceptance of this, yes, that's very important. The other thing is Intuitive is a monopoly right now. There's not another competitor. As soon as a competitor comes on the market, prices will go down.
How's insurance view this?
In the OB/GYN realm, they don't like it. In thoracic, they love it because it shortens everything. In the other specialties, it's kind of a mixed bag. But the bottom line is patients are increasingly demanding it. And that's what will drive this eventually. That's why I really wanted to show that video of those three patients because they articulate the advantages much better than I can. Yes, Ms. Chappell, Dr. Chappell.
I notice we have some engineering students here, no doubt intrigued by this. Do you have any advice for them as they think about how to interact with the surgical community to devise better devices?
The robotic companies, I can only speak for Vinci, but I know they have a very active internship program. And about 2 months ago, I had an opportunity to go out there and sit down with their C-suite folks, including their executives, their engineering folks, and appreciated from that the fact that they are very open as engineers to the clinical side of things. They're very interested in taking what they know can be done, fly a drone 5,000 miles away and control it remotely to benefit patients. So, like I said, Da Vinci is very interested in internships. I'm sure other companies have the same kind of thing. Biomedical engineering is something I'm seeing from a lot more of my physician children's, their career choices because of this exact curiosity. But it's something, it is here to stay. The application of this technology in medicine, be it orthopedics, neurosurgery, whatever, is here. So certainly look at it. It's a growing field, only getting bigger.
Other questions?
All right, well, thank you all very much. Good luck.